I'm going to give you my approach to abdominal pain. It combines two different elements. The first is the understanding of the type of pain we're going to be dealing with. And the second is sort of the model that's based on where the organs are that are causing the pain. And the idea is you create a Venn diagram between the type of pain and the organs that are affected and try to create a differential that way. You'll see what I mean. This is the Vengri robot. Before we begin, we want to talk about pain in general. Not just abdominal pain, but all pain. And all pain is broken down into three categories: somatic, visceral, and neuropathic. This is a neuron, and it innervates some tissue. In somatic pain, the problem is with the tissue itself. And that means that the nerve is correctly identifying what's damaged, what's lesioned, and why there's pain. Think about burning your skin. Somatic pain usually involves the skin. It is directly innervated by the nerve. You know exactly where it is. You can point to it with a finger. Neuropathic pain, on the other hand, is damage to the nerve, such that the thing it innervates isn't bad at all, that the nerve is bad, and the nerve is causing the pain. Generally, this is going to be a burning sensation or pins and needles. Think about diabetic neuropathy. These are going to be the people who have that burning, tingling sensation, but nothing's wrong with the organ it's innervating. And then there's visceral. And visceral organs don't have any pain receptors. Instead, what they do is they hijack the nerves above the skin of their embryologic origin, which is why if you kick a guy in the nuts, there might be abdominal pain, because they refer pain to the site of embryologic origin, which is where the ovaries are. So there's no actual pain receptors. So what organs feel is stretch and obstruction. You have to be a hollow viscous to feel obstruction, but it's stretch and obstruction. That's what's going to cause pain to an organ, or it's going to come in contact with something that's somatic, like the peritoneum. Visceral pain, so called because it is of the viscera, comes in a couple of forms. The first is obstructive. This must be a hollow viscous, and what happens is there's some sort of peristalsis. And the peristalsis comes up on the obstruction, and it really hurts because it can't push anything through there, though it's trying, and then the peristaltic wave passes over the obstruction. Pain goes away. Obstructive abdominal pain is going to be colicky in nature. And because it's only an obstruction, there's going to be no fever and no leukocytosis. It'll be non-toxic. Think about the diseases like cholelithiasis and nephrolithiasis. Notice no itis in there, just the stones, just the thing that's going to obstruct the hollow lumen. When the pangs of pain come on, there is no comfortable position. They will writhe around, trying to find a position of comfort, but they can't. Inflammatory pain is when the pain becomes constant. And because there's inflammation, there is going to be a fever, and there can be a leukocytosis. The person is going to be writhing around in agony. And there is no comfortable position. But the organ is inflamed itself, and so there's nothing to prevent them from moving around like that. I want you to think of this of cholecystitis and pyelonephritis. If the inflammation is allowed to go on long enough, or the person predisposes themselves for perforation, they might perforate. And the person who perforates is sick as shit. They have the constant abdominal pain, only they will be motionless. Perforation of anything, blood in the belly, gas in the belly, stool in the belly, it's all an irritant to the peritoneum. And they come to rest at a certain point, and the peritoneum gets used to it. If they move at all, whatever's in there comes into contact with the new peritoneum and it hurts like crazy. So they will be there laying still. Here, you can get an x-ray, and it will help you. The x-ray is going to show free air. You have to do an upright film, but if there's true perforation, you'll see the air, done deal. Things that can perforate are going to be things like peptic ulcer disease, cancer, or penetrating trauma. If what you have is ischemic pain, the patient is going to present with pain out of proportion. Boop. They will be soft. They'll be writhing around in pain, and you're like, what's the matter with you? And if you touch their belly, it doesn't change the exam at all. If you touch their belly, it's soft. There's no peritoneal signs at all. But they might be very sick. That's because the bowel is dying and is becoming toxic. So if you see pain out of proportion or a bloody bowel movement, this is towards the end of ischemia, or florid sepsis, be concerned for ischemic injury. The people who get ischemic injury are going to be those with risk factors, so coronary artery disease and other atherosclerotic disease, AFib, and they'll get mesenteric ischemia. And I say this last fifth one because it's important to hear. Referred pain happens. Women on their menstrual cycle may have abdominal pain. The old person in the nursing home might just be constipated. These people don't need a CT scan. So while you go through this process, realize that it's not going to capture everything. In the back of your mind, think about referred pain. All right, this is the type of abdominal pain, sort of type of pain in general. And what you want to do is identify what type of pain it is, to consider which type of diagnosis it could be, and then point to the location using the angry robot. Thus, the Venn diagram between the angry robot and the types of abdominal pain become the Vengry robot. Now, the angry robot starts off as a quadrant system. That doesn't quite cover it all, because you have to consider the epigastrum. So we give him a head. And it wouldn't be much of a robot if he didn't have a body. And so sort of the rarer causes of abdominal pain are put in his body. And if you want a thorough list, check out the intern guide content. And if we give him some legs, some feet, some arms, it becomes the angry robot, or angry eyebrows. Now we have a combination of the quadrant system and the tic-tac-toe method that sort of becomes useful. You've got the right upper quadrant, the left upper quadrant, the right lower quadrant, the left lower quadrant, the suprapubic region, and the epigastric region. Start from the top down and build the organs as you see them. Right upper quadrant begins at T4. If you take a big deep breath, at T4 is the lung. So consider right upper quadrant pain to be lung, diaphragm, liver, gallbladder, and biliary pathology. The mirror on the left is going to be lung, diaphragm. But there is no liver or gallbladder. Instead, there is a spleen. The right lower quadrant doesn't have too many things. You're going to have the kidneys and ureters. Ovaries and testes. And the colon. On the right, the colon is the appendix. On the left, the colon is going to be diverticula. You still have the kidneys and ureters, and you still have ovaries and testes. In the suprapubic region, don't forget about the bladder, and in females, the uterus. And then in the middle is going to be those sort of diffuse things that we're going to consider only towards the end when we're not sure what else there is. This is going to be things like constipation, DKA, and mesenteric ischemia. Just as we did for the upper quadrants, the epigastric region needs to consider things that might be in the chest. The heart is a visceral organ, as are the lungs. So when you're in the epigastric region, there's a lot more you have to be concerned with, because you could have the heart and the pericardium that goes along with it in the aorta. Right? So think of the cardiovascular system. Behind that, you also have part of the GI system, which is the esophagus. In front of that is the pancreas and the stomach in the way of ulcers. All right, so what you would do is figure out which quadrant or which location the pain is in. Name the organs that could be involved. Identify what type of pain it is. And that will give you a very narrow differential diagnosis. When it comes to abdominal pain for the shelf, the only thing you have to decide is if you go to surgery or not. We've talked about this before in other lectures in this series. If they are peritoneal, they go to surgery. Peritoneal is defined by involuntary guarding and rebound tenderness. You don't need imaging. But if they're not peritoneal and you're trying to find out the answer, you do need some imaging. The right upper quadrant ultrasound should be one word. Right upper quadrant ultrasound. There is no right upper quadrant ultrasound without right upper quadrant ultrasound. I mean that because almost always the right upper quadrant ultrasound is going to give you the answer for right upper quadrant abdominal pain. Otherwise, it's going to be the CT scan for the other quadrants, with IV contrast, if possible. Make a Venn diagram, types of abdominal pain, against the location of the pain and the organ it could potentially be, and you've got the Vengri robot. My approach to abdominal pain.